So welcome to week 5. I think that probably for me, knowing students, it's probably the hardest for you all to understand. It is those cardiac conditions, which most of it we'll discuss about is congenital heart defects. There are some similarities in the adult world in like congestive heart failure, but I'll tell you when those things happen. And then of course, respiratory. And children do present differently, especially the infant. So it's pretty rough. I did send a message and said it would help you if that you did review the interactive lecture before you came. I know sometimes you can, I know sometimes you can't, but I'm going to try to make it understandable for you. Now, I worked in Nicholas Children's cardiac intensive care unit for 10 years. I opened the unit with a premier physician who's still there, who came from Harvard in Boston, and he's still internationally known. And I basically ran the night shift. It was so much fun. I enjoyed it. I understand the heart. I can see it in my head, so I was, they call me still today, and I've been gone out of there 10 years. They still call me great grandma Boop, because my name was Betty Boop at the hospital. And they're still saying this is the way she taught it. And it still stands, and have them remember things. So cardiac intensive care is very close to my heart. I understand it. That being said, you have a question, stop me. Okay, I will try to make it more understandable for you. So it's chapters 40 and 42. Any questions to start with? We'll do the PowerPoint, then we're going to go to a Kahoots, and it's going to run right up to time today, okay? It's a lot of information. And of course, I'll get it posted for you, tomorrow. I did send you a matching sheet, and that cardiac, it was on the last announcement with exam grades are up, and it also said, important information regarding 5. So it's there. It is a matching cardiac respiratory sheet. And I go through those things that you really need to understand. Okay, so if you can answer those questions, you're doing good. But tomorrow when I post the recording, I will post the answer sheet. So you're going to get it too. So you know what you've done is right. So let's start with respiratory. Now, respiratory, we talk about infections, whether it's oropharyngeal, mucus, coughing, ears, or lower, which is usually your pneumonia. And sometimes in the lower, it's also asthma, because that's the lungs all inflamed. Most upper respiratories are viral. That's why you go and you take your children, or you heard somebody brought children to the doctor, and his temperatures are 104 and they're upset because the doctor gave no antibiotics. It's because most of them are viral. It is really to go to the doctor if you've had a fever for 3 days and it doesn't go away. Then they're going to put you on those antibiotics. But most parents within a day or two are already there because they're concerned. 104 fever. I mean, I'd be concerned too if I didn't know any better, right? But most of them are viruses. Now, after 3 days, if it continues with fever and the cough, then you get the antibiotics. And most likely they'll send you for a chest x-ray if they don't hear anything, or if they do hear stuff. Now, we're starting to talk about infections, and we're talking about all ages children. We know the infants are the ones that are most vulnerable, right? We know, especially, as I said, first 6 weeks are insanely vulnerable. And then all of a sudden, 2, 4, 6 months, we're getting all these immunizations. Now, yes, you have mom's antibodies, but their body themselves has absolutely no protection against viruses. These are things that as we get older, we get these viruses, we build up our immune system. And as we get older, our immunity is like so much better. But under 3 months, it's mom and a little bit of those immunizations, and you're going to get sick pretty quick. From 3 to 6 months, now mom stuff is weared off. It's mostly now the infant. So they're going to start getting viral infections, the cough, the cold, the breathing hard, and all of that junky upper respiratory stuff going on. By the time you get to toddler and preschoolers, this is the age of what I call swapping spit in the daycare. friends. It's like one toy from me to you, and we're sharing germs. It's actually okay, because what you're doing is you're increasing their immune system really quick, because of all of this kid and this kid is, I'm getting all of their viral things. So now my immune system is working really good. Now, by the time you get into kindergarten, 5 years old, then it starts more with the bacterial, the mycoplasma and the strep pneumonias, etc. Now, ears and all of this upper respiratory, we know mucus tends to go from a place of least resistance. And if this is all the mucus here, it's going to push to a tube outwards to fill up all of that mucus that you get. So it's going to go from the nose, and because it's so short and so open and so straight, it's going to go up into your ears, a lot of the mucus in the nose. That's one of the concerns with upper respiratories, to watch out for those ears, because it does that. Now, what do we see? What do we see with children? Well, sometimes you will see all of a sudden a kid will stop eating and sit in the corner and be quiet. And you take their temperature and they have a fever. Sometimes that's it. Children, when they're sick, they don't eat. They're not like adults. I mean, adults will continue to eat whether they're sick or not, because they want to eat the food. Children, no. And they'll stop playing, they'll sit in the corner. You might see a fever sometimes, and even low-grade fevers. You feel horrible when you have that fever. So you stop eating. Sometimes you might vomit, have a diarrhea, or more than a vomit, diarrhea, more than that, and some little bit of tummy pain. As it continues, you're going to see that cough. Maybe they're like touching their throat, or or just putting their hands in their mouth if they're younger. They're telling you, my throat hurts. And we can see if their noses are full of, mucus. What is our goal when we're taking care of a kid with respiratory problems? I have a cough, I have a cold, I have an upper respiratory condition. Well, I want that child to breathe easier. I want them comfortable, and I want them to be able to rest. I want to get that fever down, right? Because when you have a fever, these kids feel horrible. They're not going to do what you want. They're not going to drink. They're not going to eat, so get that fever down. The kid's going to have a little bit more energy to be able to play a little bit. So they're breathing better, and, they'll be able actually to sleep at night without that fever. And then, of course, we have mom or dad, or of course, Nana sometimes, that it's there to maybe give them a special juice they don't get or something, make them feel comfortable when they're sick. So as I said, ear infections are because the airways are short, open, and it goes right from the nose, goes into the ears. Now, what do we do for otitis media? Well, otitis media is an infection of the inner ear. That eardrum bulges, and the first thing you need to do is medicate for pain. It hurts. A kid with a true, real otitis media hurts. Now, what else do we do for these children? Well, upper airway has a lot of staph in it. And when it gets to the ears, we consider it an infection, not a viral infection, but bacterial, because there's staph in this nasal area all the time. So we'll medicate them with antibiotics. So medicate them for pain, give them an antibiotic. Now, if we have a child who has an ear infection, we need to tell parents to give them Motrin, and Motrin has anti-inflammatory in it. So it really helps for ear pain more than Tylenol. Also, the antibiotics, make sure that they complete the whole dose, and then go back to the doctor to look to make sure, is it cleared up already, or do I need another dose? If we have chronic ear infections, it could have a problem with hearing later on. So we need to treat them as soon as we can, and we need to make sure that they are treated completely. Now, some kids get ear infections no matter what we do everything right, and they need surgical correction, and it's usually tubes. It's an outpatient procedure. They go under a little bit of anesthesia, and they put the tube in. I actually had tubes put in a couple of years back in the doctor's office. And the hardest part was when they suctioned the inner ear with a little suction device, and I heard And I'm sure a kid would go bonkers if they had heard that. That's why they're put to sleep. The only reason, because it really doesn't hurt at all. Now, infectious mononucleosis, we've heard of the kissing disease, right? Well, usually we think of adolescents, kissing disease. Well, mono is a virus, a Epstein-Barr type virus. Epstein-Barr notoriously makes you feel tired and draggy and, oh, you don't want to do anything, no energy, like extreme fatigue. You have a fever, your throat hurts, and you have aches and pains, and all your lymph nodes are all swollen all over. Well, infectious mononucleosis is a virus, so you don't get an antibiotic. You treat it with Tylenol, Motrin, and rest and fever. Well, many children are, continue like a long time with this fever. So they go to the doctor, they say they do a strep test, they do maybe a flu, maybe a COVID test, everything's negative. They say, oh, you have a viral pharyngitis, Tylenol, Motrin, plenty of fluids, rest. Well, 3 days later, they're still sick, still with a fever, still feel horrible. So they go back to the doctor, and the doctor says, well, I can't find anything, but let's put you on an antibiotic. 3 days later, this same child's going to be at urgent care or ER telling us what had happened. So we're going to listen to this sore throat, fever, really feeling fatigued like too long. And we're going to say, okay, let's do some blood work. We want to do a CBC to see what the white count is, to see if there's a bacterial infection that we're missing. But we're also going to do a mono spot test. It's a blood test. Most likely it will come back positive. So they're not kept in the hospital. They don't need antibiotics. It is a virus. Remember, Epstein-Barr, mono spot positive, you got mono. Treatment, you're gonna rest, take it easy, drink and eat plenty of fluids, and treat the fever with Tylenol and Motrin, very simply. But the biggest instruction we give them is to restrict their physical activity, no contact sports. They shouldn't be doing anything like siblings bouncing on their abdomens, because their liver and their spleen can swell. Just think of your spleen as a big balloon blowed up, okay? I had a 9-year-old boy came in with his father. This is a real story, okay? He came out with everything I just said, it happened to him. So he was infectious mononucleosis, monospot positive, gave him instructions. The physician did, and I did. And we spoke to the father and to the 9-year-old boy. 1 week later, I was the primary trauma nurse at this local hospital. It's a big trauma center. And I get a call. There's a 9-year-old boy who was out on a trike, fell off, and he fell off abdomen first into a rock. He was coming by air, by helicopter, by rescue. By the time he got there, he already expired. In the helicopter coming in, he burst his spleen because daddy didn't listen. And the child, I mean, he's 9. I don't blame the child, and we gave written instructions, and I even yellowed out, no contact sports, mostly rest, protect the abdomen. And I will, to this day, I'll never forget them. So the biggest thing, tell them to protect their bellies, okay? So croup. Croup is one of those upper respiratories where you may or may not have a fever, but you're gonna have this bark, and it sounds like a seal barking. It is so loud and so coarse. The problem with croup, if we don't take care of it and decrease the inflammation of the upper airway, it can become more, and it could go into epiglottitis, and then laryngitis, which is just, the sore throat, but epiglottitis could be absolutely an emergency. Now, number one, what's an epiglottis? Well, that's that leaf-like structure that covers the trachea when you swallow, so you don't inhale your food. Now, this epiglottis becomes extremely inflamed with all this coughing and barking of croup, and it covers the trachea. So at normal, these kids can't breathe. So what do they look like? Well, almost the whole trachea is covered. There's usually a little piece somewhere that they can breathe. They usually on tripod, bent over like an adult COPD, right? Bent over. They are drooling when they talk because they're so swollen in their throats. This is an emergency. These children are brought back. They need to be placed in a room that we're able to intubate or do an emergency tracheostomy right away. That inflammation is covering their airway. So what do? Well, automatically, they're not going to be able to eat or drink, right? They can't even breathe. We're going to start an IV. We're going to give IV steroids. We're going to start an aerosol, and we're going to give racemic epinephrine in an aerosol right there. And it goes right to where that epiglottis is really swollen. And then we'll be following it up with IV fluids and going from there. I'm going to go into it more. So acute laryngotracheal bronchitis, again, croup. This is that one of those things. It's another name for it. The big long name. Just remember, it's an itis. It's a swelling of the oral airway. Treatment. This is similar as we go forward into epiglottitis. So the croup is just that after a cold, it happens. And it starts with this inspiratory stridor, okay? Is that they can't get air in. It's easier to puff it out because it puffs that epiglottis up, right? Because that's part of the swelling going on there. They're going to have some sternal retractions. You know, you're going to see supraclavicular. You're going to see the abdominal breathing. You're going to hear it going on. And if we do not give something to decrease that inflammation, they're going to go into respiratory distress, hypoxemia, and respiratory failure. So croup in itself is not a big deal, but it can become one of those things. So management. Well, number one, we need an airway. So somehow we're going to have it, whether we're going to have to, you know, intubate if we possibly can, but that probably is a maybe, because remember, everything is swollen covering that trachea. Maybe a trach. I've never had to do it in my career. And I've seen a couple of these, okay? But it could happen. And as it goes further, we need to keep them hydrated. At this point, they're going to be intravenously, and we're going to be giving them some oxygen. You know, and the oxygen does what? It just relieves hypoxemia. Okay, it doesn't do anything else with excretions or whatever. It is just to relieve the hypoxemia. And that moist air actually really helps with just giving some oxygen. Now, that nebulized treatment, like I said, that racemic epi goes right into where it needs to go, because it's not the airway. It's not like a rescue. It's just right there that's swollen up. And of course, IV steroids. All right, another thing that happens, and for you and me, respiratory syncytial or bronchiolitis, it's the same name. It's RSV is bronchiolitis, okay? So the short name of respiratory syncytial virus is RSV. RSV is bronchiolitis, different name. Now, for you and me, this is a common cold. And it's just a lot of mucus in your nose. Now, think about if you were an infant, you know, a young baby. Now, you're obligatory nose breathers as an infant. So you don't breathe through your mouth, even though you could. They don't know how yet. It's just part of their growth and development. And the nose gets full of secretions. How are they supposed to suck, swallow, and breathe? It's hard. So what do we do for these children? Well, in nursing care, we're going to make sure we tell the parent, or if they're admitted, and not all of them get admitted, just to keep the nose clean before they feed a baby and to give them rest breaks, because suck, swallowing, and breathing is a lot to do. Now, what if you were a cardiac child too? You already are compromised. You already are less than normal O2 saturations. You want to prevent them from getting RSV. There is a vaccine. Now, the vaccine is called Synagist, and it's given in fall to early spring, and it's monthly. Synagist is given monthly, and it's one of those, it's pavizilmab, it's one of those biologic medicines, and it's used for RSV and prevention. So at home, what do? Suction the nose, feed the child, but let them have rest breaks because they're going to have difficulty sucking, swallowing, and breathing. Okay, pneumonias. Now, pneumonias are that diagnosis in children. Sometimes you only see a fever and they vomited once. I mean, many times. If they're coughing, okay, that gives you some more clue. But not eating, fever, vomited once. There's a lot of mucus coming up. It's usually the symptoms you see. Now, with pneumonia, it is an infection usually, although there is viral, but most of the time physicians don't mess with pneumonia. They do give antibiotics for it, just to be sure, because there's something in there consolidating into the lungs. What causes pneumonias? Well, as I said, you have bacterial and you do have viral. Now, the viral, we just Tylenol, Motrin, but I'm telling you, usually they give antibiotics. Mycoplasma, this is very more hard to diagnose, and requires, different antibiotics to take care of it. Pneumococcal, we have a vaccine for now. So not many children get that because we give that vaccine. Now, pertussis used to be one of those things that was wiped out with immunizations, but a couple of years back, we saw it back in pretty well good force here in South Florida even. And what happened was there are children that the parents say, I don't want them immunized for whatever reason. There are religious things, there's, literature out there that they read, whether it's good or bad, it's a parent's choice and they don't want to be immunized. Well, I want to wear a mask if you're not immunized, but it's like that. Now, pertussis is a respiratory illness, so it's spread by droplet. And it's coughing, coughing, coughing also, whooping cough. And it does sound like whoop, whoop as you're coughing. It's extremely contagious. And of course, the younger kids are the ones that are going to be more problems with it. If they have to be admitted, they have to be admitted in those rooms. It's called a reverse airflow, where the air goes outside, not back into the hospital system, because it can spread very easily. But as I said, there are vaccines for it. Foreign body aspirations, kids explore the world how? In the mouth. So everything, swallow it, it's going to happen. In children, I have actually seen mostly coins, and I've seen mostly quarters, not dimes, not pennies. The biggest one is the one they tend to swallow. And if you look at this x-ray, that's exactly what it looks like. With this child has swallowed a 25-cent piece, that quarter right there. How do we treat it? Well, number one, you're always worried about airway. You as a nurse, that's your concern, because they will be drooling, but they be able to breathe okay, but it hurts. That big round thing in the esophagus hurts. So today, what they do to treat it, they don't take a bronchoscopy and pull it out in the OR anymore. That used to be, no more. They take a Foley catheter with a balloon on the end, put it down below the coin, blow it up, the balloon, the child sitting on the surgeon's lap, bent over, pull it out. They usually vomit and the coin comes. And before the surgeon does that, I said, when he pulls that out, whoever gets the quarter first gets it, and I'm going to get it first. So this child now is not worried about this coming out. He's worried about me stealing his quarter. So, and I'm telling you, the kids go right to the floor looking for it. And then I know they're okay, right? So again, distraction, it does work. And these children do respond to it. After it's out, again, always you're gonna have to monitor the airway for a while to make sure there was no irritation, et cetera, et cetera. But they go home the same day. It's better than staying overnight because you went to the OR and had some anesthesia, right? The other thing is aspiration pneumonia. You know, years ago when I first started in the NICU in the 80s and 90s, you know, these children, it was Johnson and Johnson baby powder, and boy, did it smell really good. So I used to always have it on them because I love the smell. Well, then we realized the talcum in the air was hurting their airway and we were doing a lot of harm. So we don't use powders anymore. Another way they can inhale stuff is if you go into the bathroom and you're cleaning it with all these chemicals, you know, the child goes in, you know, sometimes you cough because you use too strong of something, bleach or something to clean, you know, the bath. Well, children shouldn't be in there because their lungs are even more sensitive than ours. And then the third way they can get aspiration is by reflux. You know, infants, many of them have reflux. Could be due to many different things. Could be due to overfed. They swallowed a lot of air. They weren't burped enough, and they should be sitting up after they feed. You know, so they're overfed. It has to come up, and it refluxes, and it can cause aspiration pneumonia. So how do we treat it? Well, usually formula and breast milk at first. We don't put anything but that. It's all they drink. But if we put 5 mLs in 2 ounces of rice cereal, now it's going to come right out in the stool. It's not going to have any nutritional value, but it thickens that formula and it holds it down, and they won't reflux as much because it's held down with the rice cereal. It thickens it. Acute respiratory distress syndrome is also called ARDS, has to do with some sort of injury to the lung, whether it is overwhelming infection, sepsis, or maybe they were in a car accident and they hit their chest. You know, drug overdoses, you know, adolescents, that would be the group you'd see there. And then, of course, near drowning. Near drowning is something that I've seen a few of here in South Florida. Now, many times you will see the mother said, well, yeah, he was under, but we got him up and I smacked his back once and he's spit out water and he's running around, he's fine. The problem is you could go into respiratory distress with a lung injury up to 72 hours later. And they should be admitted, and they should be admitted into like a step down unit where they're at least monitoring their oxygen saturations. And they can go to the point of requiring intubation and ECMO and, you know, really, really sick. So they really need to be watched. Most of these children, ARDS, they go to that point, they're sick, and mortality rate is very, very high. Now, this picture here is what we call ECMO. It's where we take blood out, we oxygenate it, and we put it back in. I used to run one of those machines. Nurses do these machines. You're taught, you take a course to do it. And it's interesting. Mostly are newborns with like meconium aspirations, but they're used for drowning also on your older children. So it's something I'm very familiar with. But the longer they're on this machine, the less their probability of coming back is. Now, CPR, we all had to take CPR to go to nursing school, right? So, but what about the family? You know, you're working any area in the hospital, you can have a child who needs life-saving, right? Remember about the family, and remember that mother, that father, when you pull them out of the room, you're separating them. And they were like, well, if they die, they didn't see me or hear me last. Can you imagine that? So as long as that hospital allows it, have those parents there. It's very, very important. Now, if there is this hospital policy, they got to go, make sure somebody's staying with them and keep them well informed and make sure the physician goes out after the event and let them know what the outcomes are going to be. It's very important to be there for these parents. Now I'm going to give you a scenario. You go into the cafeteria and you're the first one in for lunch today, and you noticed on the floor is a 6-year-old boy all alone, unconscious, not breathing. What do you do first for CPR? Unconscious, unsupervised arrest. You start compressions. Number one, you start compressions. Years ago, you'd have to give 2 breaths and then start. Not anymore. They feel there's enough oxygen left in the vessels that at least if you're doing compressions, you could save more lives, because many people didn't go to do CPR because they felt they had to do mouth to mouth. And today's environment, they don't want to do that. So at least if they're doing compressions, they're okay. And I think you have to do 3 cycles of 15 and then call for help, okay? Asthma. This is one of those conditions. I think many children have asthma, one of those common, diagnoses. And it's basically a hyper-responsiveness of the lungs. They get swollen, and they get big, and there becomes irritation, and it's cough, 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 cough. And this one is prolonged expiratory phase. They can get air in, but it gets trapped, and they have to push it out. And usually at the end of the respiration, you hear like, if you listen to their lungs, huge, tight wheeze you would hear. So how do we manage asthma? Well, it doesn't matter, adults, children. I mean, it's just the changing of different types of medicine, but we treat them the same. We need to look at their lungs when they're doing well, see what their functions are to make sure we're maintaining that. And then usually asthma is due to an allergen. So go to allergist, find what allergens are going on. Is it the cat, the dog? Is it grass? Is it, bed mites? What dust? What is it? And then maybe this child can be removed. Maybe it's the cat they just got. Who knows? Or we could try to desensitize them so that they don't have these allergies anymore. We know that they're going to get that little MDI, meter dose inhaler, for rescue. And that is going to be your Advair, your albuterol, Proventil. Those ones, those are your rescues. Now, one of the things I've learned is when you get the younger kids in, doctor's office, doesn't matter, urgent care, ER, and they asthma, and you can hear them wheezing. Usually it's audible on expiratory. You can hear it. You ask them, so have they been taking their puffer? And they'll say, yeah. And you ask how, because that little thing that little boy is holding is called a spacer. And now if we puff 2 little things in that little chamber, when he breathes in and out, he's going to get the dose. How many kids that age can puff and inhale at the same time? Yeah, ain't going to happen. So that spacer, even some adults can't puff and inhale at the same time. They have adult sizes too, just in case. But if they're still wheezing, they're on albuterol. That would be my next question, because they probably aren't getting the albuterol. If I've already had 3 or 4 doses, it's not working. So albuterol is for rescue. Children get a morning and night type of aerosol that we give them. And one of the most popular ones I've seen is called Pulmicort. It's like a Symbicort, Brio, Advair in the adult world. And it's a little bit of steroid in it and helps stop the lungs from being hyperreactive, okay? It's like a preventative. It's not for rescue. It's only to try to prevent it. Then we also give Singulair. Adults, children, don't matter. They're giving it from age 2 up. They're giving Singulair now. And then if we're in an acute stage and they had to go and get treatment, with the doctor or whatnot, usually they'll put them on some sort of steroid, whether it's some prednisolone on children or Solumedrol IV if they're that bad, some sort of steroid to decrease that inflammation. Okay, let's go into cardiacs now. Now, cardiac is a hard chapter. Now, I want you to think of the way blood flows and make that into the garden hose. And if I put a kink somewhere, think backwards where that blood would flow, okay? That's gonna help you understand. So there are two types of cardiac defects. You're born with it. It's called congenital. And then there's that acquired. I think the infection, usually it's a viral and it goes into myocardiopathy. I mean, those hearts get big and floppy just due to a virus. Autoimmune, well, what about lupus? Lupus attacks hearts, right? So it could be that, or it could be some chemical spill, something environmental, or it could be familiar, coming down, the line in the family. Now, this picture, first of all, let's trace a drop of blood as it enters the heart. So we come from the superior inferior vena cava, and it just goes in and it drops into the right atrium because it's gone through the whole body. So it enters the heart, the right atrium. It goes through the tricuspid valve into the right ventricle, up the pulmonary artery, pulmonary valve into the pulmonary artery into the lungs. It returns with 4 pulmonary veins into the left atrium. So there's a lot of high flow there. Goes through the mitral valve into the left ventricle, which is your big engine of the heart, through the aortic valve, and it goes up the aorta arch to the body. One of the first branches off the aorta is going to be kidney. So we can see if there's problems in the aorta just by urinary output. We'll see decreased in flow. Okay, I'm going to give you your first congenital heart defect. Take that aorta after those little 3 subclavian and carotid arteries going up, those 3 ones, go after that, coming down, kink it. Make it a smaller area. There's a kink in the hose, isn't there? So what are you going to see down at the feet? Decreased blood flow. What does that mean? You're going to have no pulses in the feet, dorsalis pedis, posterior tibial, or there's going to be a little, maybe a little faint little pulse. So this is giving me some clue. I really don't feel pulses in the lower extremities. This sounds like coarctation. It's the only defect that does that. So what am I going to do next? Well, it happened to me once. I was really actually brand new into the newborn nursery, but somehow I remembered this. And I did 4 extremity blood pressures. So if there's a kink and not a lot of blood flows going down, the lower extremities has a lower blood pressure. But those 3 little vessels that goes upwards and back into the left ventricle, blood's going to go back because it can't go down. It has to go somewhere. So it's going to go up into the head, and it's going to go to the upper extremities, and I'm going to have higher blood pressures in the upper extremities. Now, sometimes these kids, they miss them as infants. They don't see it. And somewhere older, all of a sudden this kid's complaining of nosebleeds and headaches. That's that extra, those 3 vessels going up to the head, that extra pressure because it can't go down to the feet. And sometimes it's the only symptom you ever see with coarctation with your older children. Younger children, infants, that blood goes back. Yes, it goes to the upper, but it also goes back into the left ventricle, and it goes back up the left atrium and back into the lungs, fills up and causes congestive failure. Because that's where the hose empties, right? You have a place there to fill up. So that's what it does. So you've just learned coarctation. Check pulses, lower extremities. If they're minimal, you're going to check 4 extremity blood pressures. And then if this is an older child, listen to the lungs. Is there fluid in the lungs? Probably all will be there. Now, children who are cardiac and they're confused, and let's say they're 2, 3 months old. I mean, I still remember this little girl, 3 months old. She was a coarctation of the aorta, and parents kept bringing her to the ER, and they kept missing, but she wasn't in a pediatric cardiology area. She was on the west coast of Florida. Most of the cardiacs on the east coast, okay? Seriously, not everybody understands pediatric cardiac issues. So continued, poor feeding, tachypnea, she was tachycardic, she wasn't gaining weight. Well, if I have this coarctation filling my lungs up, I'm full of fluid, I can't breathe because I can't get all the oxygen I need. If I can't get oxygen, I'm going to tire easily, and I'm not going to eat, and I'm going to lose weight. Makes sense. Not getting enough nutrition, then developmental delays, cognitive delays, right? You might see it in, the prenatal, you may not. And you might know if there's some sort of familiar history, but maybe not either there either. We'll be looking at nutritional status, how much they're eating, how frequently. I mean, if a kid is blue, cyanotic, that's easy to determine what's going on. Their O2 saturations are low, but you don't always get that. Not with this coarctation I was talking about earlier. She still looked pink. She still had 90-something saturation. So it wasn't that she wasn't, exchanging oxygen. It was just that she was filling up with fluids and she was struggling now. You can feel the chest vibrating, this pulsations, you can feel it. And as they get older, you would see things like clubbing of fingers. I have a picture later on, but newborns, yeah, they don't have clubbing fingers yet. So we're going to look at the chest. We're going to listen to the abdomen, feel peripheral pulses. We're going to look at the heart rate. I mean, a normal heart rate on a newborn infant is 140 to 160. So if it's 180 and they're sleeping, something's going on. That heart's struggling, right? And then if you look further, I mean, O2 sats are a little bit low. Guess what's going on here? Most likely, this is congestive failure. This could be that scenario that's going on there. And of course, are there any murmurs? So what do we do for these children? Well, EKG is always number one. And then we do an echocardiography. Now, these echograms, what they do is they look at blood flow, somehow squirting around, seeing if there's those valves, etc. And if we see anything that's going on, prepare that family for a cardiac catheterization. And a cardiac catheterization is usually the next day. They don't mess. They want to know what's going on. They want to know how to treat these children, how to oxygenate them, what happens in case of emergency, et cetera, et cetera. Now, when you do the cardiac catheterization, they're either diagnostic or interventional. Well, diagnostic was we saw something in the echo. That's your diagnosis. Go back and look. Look at flows a lot better there. Interventional would be, I've seen it done two ways. I've seen it where we've done the electrophysiology studies and we told an area in the right atrium that was trying to beat on its own to slow down. We don't want that. And we would zap those areas because we want the pacemaker of the heart, the SA node, to be the pacemaker. We don't want any other little foci in that right atrium to work and beat, because the normal heart rate for the atriums are actually 240 beats a minute. So we don't want that. We want the normal, which is what the SA node delivers. But the other areas are like that, would beat way too quick. So we zap. So sorry, we don't need you to do that anymore. So zap it, and now the SA node can take over. So that's electrical physiology studies. Interventional, we actually can fix holes in the heart with something called a helix device, where during the cath, we go in, it's like two discs, we put it through the hole between the septum, whether atrial or ventricular, and it pops on the other side. So it is preventing flow from going back and forth. It's like putting a Band-Aid on either side so that the blood stays where it should. So you don't have to do surgery. It's just a cardiac cath. Nicholas Children was one of the first ones who did it. Cardiac cath, your job as a nurse. Well, pre-op is like a pre-surgical type thing. Get the patient prepared, all the consents, whatnot. MPO, according to what they're eating. I mean, breastfed babies can eat up to like 2 hours before. In formula, they say 4 hours. But they, of course, we want to maintain their sugar levels. So, you know, as soon as we can till they go is when we want to feed them. Now, post-op. Now, they take two vessels, the right femoral and right femoral vein, the artery and the vein, and they use those for catheters to go in to look and do a cardiac cath and to look at blood flows. And when they're done doing their procedure, and these children are asleep, like with anesthesia, they pull out the catheters and they apply pressure. And these little catheters are huge as comparative, especially if you look at a newborn baby. So what they do, they pull them out, hold it, you know, they put their, this is the hole, it's right above it, closer to the heart, and they can watch it to make sure it's not leaking. When it's okay, they put a pressure dressing on it, send them back to the room. Well, we know that there's jostling from the cath table to the stretcher to the this, and movement and bouncing in the hall or whatnot, that clot that was there could dislodge. Think about an infant and these two big holes in the femoral artery and femoral vein. A lot of blood could happen, and it could happen really, really quickly. So the first thing you're going to check is that dressing. And if you see it's any blood, you're going to put your fingers immediately where those femoral artery and femoral vein are and push down. Usually, you say somebody, you know, get the doctor. Now, that's all we're going to do is, though, that's the treatment. But the doctor needs to see, you know, how much blood came out, you know, if there's other intervention, do they need to get blood, fluid, whatever. But you push it down and then you wait. Once it clots again, you put a pressure dressing on. Older children will put a sandbag there to hold it. So nursing care after that. We got the bleeding under control. You do vital signs. Usually they have an IV, but we check glucose levels because if they haven't gotten any sugar during this procedure, younger kids might need a little sugar. So we want to check on that too. That right leg must maintain flat and straight. We don't want to dislodge that clot. These children are not allowed out of bed for 24 hours. Because we don't want to dislodge that clot. They can take stuff by mouth, they can eat. We slowly can put the head of the bed up, but they cannot get out of bed. Legs straight, not out of bed, and then they can eat if they want to by mouth. Now, when I went and opened up this congenital heart unit at Nicholas Children's, we got this really great surgeon from Harvard, as I said there. I didn't realize how many cardiac children there were. I mean, I've always gravitated and I understood them. My mind just, I don't know, I just like hearts. And I really got it. So when they opened the unit, I went, I'm gone, and I was there. Now, one of the children that you see getting a lot of cardiac problems, congenital, is your Down's children. Down children, a lot, you're going to have a simple VSD, AV canal, truncus. Those are the three things. Rarely is there nothing. Usually a Down's child will have some sort of cardiac condition. So in hearts, congenital heart defects, there's two types you need to know. One is acyanotic, which means they're having a really good O2 saturations, even if they have whatever the defect is. How about an ASD, a hole between the atrial septum of the right and left atrium? It's got a hole, but still it's going to the lungs. We're getting it. Also, the ventricles, ventricular septal defect, it's fine. There are things that don't decrease O2 saturations, but there are some that are cyanotic. I'm going to go into that with the next slide. And the one thing we need to think about as we are kinking the hose with these defects and the blood's going backwards, where is it going to go? It's going to go to the area of least resistance, right? So we know blood just comes back into that right side. And we know the left side, you've got 4 pulmonary veins flowing blood back into the left atrium. And we know that left ventricle's got a big pump on it. That's your engine. There's a lot of pressure on the left side. So if there was a hole in any septum, it's going to go from left to right. Very easy. Make sense? And that's shunting. That's just what I want you to think about. Where would it go? Path of least resistance. So acyanotic, we do first here. So there are, if you have a hole in a septum, you're getting blood from the left side to the right side, right? It's going to shunt left to right. What's going to happen? It's going to go back into the lungs again. So that's increased pulmonary blood flow. Makes sense? Yeah, it's the way it goes. Now, the one you need to understand here, and it's a little difficult, and you're going to hear this, about 20 times at least tonight, is something called a patent ductus arteriosus. It's also called a PDA. A PDA is fetal circulation. It's that little tube that connects the pulmonary artery to the aorta. So the lungs can give the body systemically oxygen, right? If it's open, it still is going to push oxygen to the body if there's no other connection. So it's a good thing to have. And we use it for many different diagnoses. Now, the patent ductus arteriosus, the PDA, is kept open by a hormone called prostaglandins. Mommy makes it when she's pregnant. After delivery, mommy's gone, so it stopped being made. So it usually, not all the time, usually will close pretty soon after birth. They say up to 21 days, but it's usually pretty quick. So if I needed to have that PDA kept open, it needs prostaglandins, right? Well, we have synthetic prostaglandins, and we can give a slow, continuous infusion of prostaglandins, which keeps that PDA open, which keeps oxygen going to the body. Now, what if you're older, and that PDA didn't close and I don't need it, and it's just causing a lot of extra flow going back to the lungs and the aorta. It's like all this extra flow, you need it closed. Well, there's an NSAID called indomethacin. And that blocks the prostaglandins for wherever it's coming from and says, no, stop, we need to close you. Indomethacin, medical treatment for closure of PDA. So prostaglandins keeps it open, slow, continuous IV infusion. And indomethacin is a NSAID that stops the prostaglandin and closes it when we don't need it. Now, if we had that thing open, you're going to hear a murmur with the PDA. Once that indomethacin works, that murmur, the sound's going to go away. So you're not going to hear murmur no more. Okay, the next one, coarctation of aorta. We've already gone over it. You understand it from the aorta to the pulmonary artery. It increases oxygenation and it helps with cardiac output. When their things are blocked sometimes in the heart, where there's no opening sometimes. There's two terms, stenosis and atresia. Now, stenosis means there's a little opening left, an osis. It's tiny, it's smaller than it should, but there's an opening. Atresia means there's nothing. There's no opening between whatever it connects. Usually, when we talk about atresia, we think of tricuspid atresia. And where is that? Between the right atrium and the right ventricle. That means there is no opening. So blood doesn't go down there. Doesn't go in the pulmonary artery either. So how do we get oxygenated? PDA. We keep it open. That's how we get the oxygen going to the body. So there's ways we can do things to make it work. All right, decreased pulmonary blood flow. The most common cyanotic cardiac congenital heart disease is tetralogy of Fallot. Ever hear of a tet spell? A blue baby, blue spells? Well, tetralogy of Fallot, something in that right ventricle covers up where the blood's supposed to go to the lungs, that pulmonary artery. Could be the pulmonary valve, it just gets covered and no blood can go. I've actually seen O2 sats go from 100 to 10 in less than 30 seconds on an infant, newborn. Went from pink, this is my little Nolan, I'll never forget him. Little Nolan went from pink to blue, gray, just cyanotic as could be. So what do you do when you have a TET spell? Because we need to pop that open. We need to get blood to the oxygen to that lungs quickly. And it's not putting up medications. It's not quick enough. So if we take the knees and you take the head and you push those knees right to the head, to the chest, it does something with changing the pressure in the abdominal cavity and the chest cavity. And it pops it off and it will allow blood to flow. And that's what I had to do with Nolan. It took me 3 times. And then, of course, the physician who was there sleeping came and woke up and he said, "Oh, you took care of it already." I said, "Yeah, I had to do it 3 times. But tetralogy, sometimes we, fix them in the first little bit of their life, and sometimes they wait till later. It all depends on, the anatomy that's in there. But sometimes these kids get older with tetralogy of Fallot, and older kids all of a sudden realize something's going on. And by themselves, what they do is they squat to the floor, like just sit and squat. They sit on their back of their feet, okay? And again, it does the same thing. Tricuspid atresia, as I said, no opening between right atrium, right ventricle. And then the other condition you need to know is transposition of the great arteries. Well, what are the 2 arteries that are in the heart? We have the pulmonary artery and we have the aorta. They're switched. So blood is coming that's unoxygenated, goes up the aorta to the body. And the other one means oxygenated blood goes up and goes back into the lungs. So we're not getting oxygen. So guess what we need to do to keep this child alive? PDA, prostaglandins. And these children can wait for at least a week before they have surgery. And then I think the most difficult cardiac syndrome is hypoplastic left heart. This is when their left ventricle is thickened, it doesn't work well, requires 3-stage surgeries. Many of these children end up with transplants in the end. So it's thank goodness it is not common. Tetralogy is the most. There's a couple slides for you to look through the blood flows here. I left them for you. Congestive heart failure. Well, does it matter if it's an adult or a child? Congestive heart failure just means the heart's not pumping right. Or maybe it's that kink, which is putting backward flow, putting all of that fluid back up into the lungs, but it's still congestive heart failure. Well, how do you treat adults? Diuretic and maybe some digoxin. How do we monitor if it's working? INO, daily weights. I mean, vital signs will show it, but in an infant, we are going to see INO, daily weights, we're going to see the weight being lost. One of the first things, actually, if you're looking at a kid and seeing them start to struggle, you're going to see their urinary output is going to start decreasing because that urine's going into the lungs, right? They're not getting rid of the fluid. The heart's not beating good enough to get that to the kidneys to get rid of. So decreasing urinary output's part of it. So congestive heart failure, you're going to take an x-ray, we're going to see it, we're going to listen to it, we can hear it, right? So the goal is to improve that cardiac function. That's the digoxin, that's the Lasix, get rid of it, get rid of all the fluids. It's going to decrease cardiac demands. And as we decrease the amount of fluid in the lungs, there's more areas to breathe, and we're going to improve tissue oxygenation. Makes sense. So again, same thing I just said, improve your cardiac function, decrease cardiac demands, reduce respiratory distress, and all while maintaining nutritional status. These children can get tube feedings, that we could still give them nutrition, or hyper-al if they're younger children, but we always watch for nutrition. And we need to teach these parents what has gone on with that child, because a cardiac child could do this at home. And we want them to understand what they look like and what needs to be done, so they can get them to us quicker, so we can do quicker interventions which don't require hospitalizations, etc. I told you I'd show you a picture about clubbing. Here's an older child. Those fingers, those rounded, absolutely what clubbing looks like in a younger child. And this kid could be about 10 years old here. Now, one of the things with hypoxemia is some of these cyanotic heart diseases at birth, O2 sats of 75% are okay. And that's a hypoplastic left heart. After first stage, after second stage surgery, it might be 85% their O2 saturations. And by their third stage of all of this stuff we have to do, if we get it 90%, we're happy. So they're always a little hypoxic. You see this, right? So the body says, the body doesn't know that they're hypoxic due to a cardiac condition. What it thinks is, how can I get more oxygen to the body? Oh, let's make more red blood cells. And it makes more red blood cells to get the oxygen, but there's no oxygen to hang on to it. So your O2 saturations are still going to be the same. It's still going to be hypoxic, but you got all these extra red blood cells. So what do you see? Well, normal hemoglobin hematocrit, 1442. Well, they could be 18 or 19 over 54, 58. It can go that high. Thick, dark red burgundy blood, because they're polycythemic, because the body's making red blood cells. So again, cardiac, teaching them from whatever's going on, let them know what's going on. Cardiac parents are usually the smartest people, and they really are involved because they know it's not just once that they're having a sickness, something they're going to have to monitor for a long time. And they really want to know. So get them involved with pre-op, post-op, daily care, and what you're doing and why, what medicines and why. And this will help these parents take care of these kids. Bacterial endocarditis, adults, children, don't matter. We have an infection of the endocardium, and we're going to be giving prophylactic antibiotics before any procedure, whether it's dental or maybe a cardiac cath. Now, rheumatic fever. This is a disease caused by a strep throat that was not treated completely. There's two illnesses in pediatrics that are caused by strep throat. Rheumatic fever is one of them. And what happens is it affects the joints, the skin, the brain, the heart. And it's also can cause like chorea, which is a shuffling gait thing. And usually that's when they bring him to the doctor, like he's falling over, something's going on. And then they look at the rest of it. They'll get a history, find out they had a strep problem. They'll be doing what we call an ASO titer. It's an anti-strepolytic titer. It's a blood test, and we can see the strep in the blood. So how do you think we treat this? Give antibiotics. We're going to treat the strep, but it's going to probably be a month, maybe 2 months antibiotics treatment. And the only concern is if it's already damaged a valve, and it will usually damage the mitral valve. Children get high cholesterol. We never knew that before, but now we're starting to test. How do we treat adults? Well, we change their diet or we place them on medicine. Same thing. cardiac dysrhythmias. Children can get slow, fast, and irregular heartbeats. They're a person, and all people, all ages can get it. If they have a Brady dysrhythmia, well, I know some even 2-year-olds have pacemakers if we needed to for Brady dysrhythmias. So depending, tachydysrhythmias, well, maybe they need an electro physiology study to zap an area, and that could be done. Or atrial fibrillation, other stuff to try to slow and strengthen the force of contraction. Pulmonary artery hypertension occurs with a lot of cardiacs because all this flow is hitting the lungs, and the alveoli say, whoa, wait a second, and it gets really stiff because they're protecting itself. And what happens is then it's going to be a child who gets tired easy with minimal exertion. You might see that chest pain and they're not getting oxygen, so they might get dizzy or restless, etc. Actually, the first drug to treat this is oxygen. And do you know what they started to use on pulmonary hypertension? Is they actually introduced Viagra back in the early 2000s. And they found that that dilates the vessels in the pulmonary arteriole. So it actually helped them breathe. And I thought that was an interesting thing. Cardiomyopathy, I told you, it could be due to an infection, could be that viral one, most likely, could be something genetic, could be lupus, could be anything causing it. Any sort of metabolic collagen disease, all can cause cardiomyopathy. And usually after a while, the heart doesn't tune up much anymore, and they end up with a heart transplant. Now, the biggest concern with heart transplant is rejection. The biggest thing that causes death in children post-heart transplant is rejection. Young children, we never did blood pressures before, and now we're doing them even younger. And we are finding that they do have high blood pressures and require medicines. Same stuff that we give adults, but in milligrams or microgram per kilograms. And Kawasaki disease. Kawasaki disease is this kid who's got a fever, don't feel well, and it's been going on for a while, and nobody's can figure it out. And it is what we call a systemic vascularitis. We don't know why. We know it's not bacterial because we don't treat it that way, but it causes like little microembolus in the vessels, and we're concerned about the coronary arteries. It could cause aneurysms there, and then a blowout could cause death in child. So symptoms, what do we see? We see their eyes are red. They have strawberry tongues, cracked lips, swollen glands, peeling hands, palms of the hands, soles of the feet, and fevers. And what do we do for treatment? Well, this is the only disease you will give aspirin to, okay? And the aspirin is there because, number one, it's an NSAID, it's an anti-inflammatory, but more because it helps reduce clots. It thins the blood like a blood thinner, and that's why it's used. And then we also give intravenous immunoglobulins to try to boost the immune system to get rid of it. I had my, the director of the cardiac ICU, the doctor's son, a 3-year-old, came into our unit one night, and he was Kawasaki. And I'll never forget those big red glow in the dark eyes. I mean, very distinctive. Didn't look like conjunctivitis. It was red, different. Shock happens in any type of a person, whether they're a baby, whether they're an adult. In babies, the most common reason for shock is infection, septic shock. What do you see with shock? Well, blood pressure's down, heart rate's up, urinary output decreases, capillary refill is prolonged. I mean, confusion, disorientation, restlessness, all of these things. What you see with adults, it's the same thing with children. So somebody answer, see if you can get this one. Surgical closure of the patent ductus arteriosus does what? It closes the pulmonary artery attached to the aorta. It prevents the return of the oxygenated blood back to the lungs. That left ventricle is pushing hard, it's big flow going up, and that PDA is going to push right up into the lungs, and it's gonna, once that's closed, you don't have that anymore. I told you, it's a really heavy week with a lot of concepts. I hope I made it understandable because I know it's rough. Who wants to do a cahoots and who wants to win? Amber, you tonight? Heather? Yeah? Katie? Darcy's gonna win tonight. Lakeisha? Mia Mary. There you go. All right, let's get going there. I think there's 56. A lot of questions, but I'm covering it good for you. A majority of upper respiratory infections are caused by what? So upper respiratory, think viral. Very rarely, actually, it's an infection due to bacteria. That's why you don't get antibiotics. You walk into a 6-year-old child's room and you find them not breathing and doesn't wake up. What do? They're not breathing. They're not waking up. Annie, are you okay? So number one, start chest compressions. Then you do like 3 repetitions. If nobody's around, go get help and then continue. You know, let's save that poor kid. So review your CPR. Multi-select. What are some signs and symptoms that smaller children may exhibit as a respiratory infection? So what's a kid gonna look like? I mean, they may not be coughing yet, right? What are some things that are gonna alert you something's going on? So fever, may or may not, okay? Poor appetite, vomiting, tummy hurts, absolutely, all of the above. And sometimes it might be you vomit once, you know, or sitting in the corner, yeah, I don't want to eat. When they're not eating, especially their favorite foods, you better find out why. Usually they're sick. A multi-select. What do you look for when assessing respiratory function? Rate, depth, if they're labored or not, and of course, how easy are they breathing? You could go further. Infants, if you see nasal flaring and you hear a grunt on the end of a breath, I mean, you'll hear You hear that in an infant, you're in trouble. That kid is about to code on you. That is severe respiratory distress in an infant, that grunting. What would you look for after a child has a tonsillectomy? So you're doing your assessment, going around, or you're teaching a parent about a tonsillectomy. What are you going to tell them to look for? If they're swallowing more than usual, they're probably bleeding. Okay, that's what they'll do. They'll bleed. If there's something's in their mouth, they're going to bleed. Now, severe pain, we need to treat pain, and Tylenol usually works. They should be able to drink fluid, especially cool ones. Don't give them anything red. Jello, ice pops, juice, nothing red. High fever, actually, they shouldn't have a fever. Post-op, multi-select. Nursing care for a child status post-tonsillectomy include so Tylenol, and keep in front of it, because once the kid is medicated, no pain, they're going to be able to drink and eat a little bit better. And they do need to keep their fluids up. And that ice going down the throat with the fluids, those cool drinks really help. Nothing citrus, nothing spicy. That burns. It's going to hurt them. Soft diet, something easier to chew. I had a brother who came out of surgery at the doctor's office years ago. He wanted radishes with salt on it. And that's what he ate. He said, that's what he wants, and he wants to eat it, let him. Radishes. I don't know how he did it. And that ice bag. A lot of kids, younger kids don't want it. Older kids will keep it on there. Young kids like, no, they don't like that. A multi-select. What would you suspect if a child has a dry, bothersome cough that keeps them awake at night? Now, this is where you get in those diagnoses with those respiratory conditions, and what is what? What symptoms do you see with all of them? So dry and bothersome is tracheobronchitis or bronchitis. You know, ever have bronchitis? They give you a Z-Pack and they give you cough medicine. You cough so much at night, you can't sleep. So the codeine in the cough medicine will help you rest. Asthma's not only at night, okay? It's any time of the day. And pneumonia has some fluid in there, some consolidation. It's loose, it comes up. It's not dry. A multi-select. What signs and symptoms would you see in a child with otitis media? Kid comes in, points his ear. I mean, little 3-year-olds pointing to their ear like that. What ear? My heart just breaks for them. Number one is pain. Your priority in this child is to give them something for pain. And I'm telling you, ibuprofen works better because the anti-inflammatory in it. But if they're due for Tylenol, please give them Tylenol. They're not going to eat. They don't feel good. They're in pain. You also might see that little drainage coming out. And sometimes it's a lot of stuff that comes. They don't always have a fever. They don't always have a fever. The monthly immunization for RSV, respiratory syncytial virus, which is all nasal mucus consolidation, which in the newborn is not good. And it's called Synagist. That's palivizumab. That mab is your biologic, and that's the one that they use. Hib is hepatitis, Humira is for rheumatoid arthritis, and indomethacin, that's for your PDA closure, right? indomethacin, or indocin, same name. All of the following are signs of early respiratory distress in children, except what? So which one is late? When you have a child who's in respiratory distress, they're tachycardic, they're tachypnic, diaphoretic, they're restless, they need grunting, retracting, abdominal breathing. When they get to the point of bradycardia, you better be in a trauma room where you're going to start CPR. These children they're collapsing. Their respiratory system is going. Be prepared to assist them with breathing. Bradycardia and a respiratory, it's not good. A 4-year-old child has been taking meds for asthma. The child's still wheezing. What information is important? What are you going to ask that parent, that child? Did they use a spacer, or is it just blowing in the air? I mean, you get a child who's coming in who's coughing and asthmatic and, they're wheezing. I want to know, are they getting the medicine? And if I find they're not, then I'm going to give them a spacer and give them that medicine right away. And probably I'm going to see an improvement in the wheezing, right? Hopefully. An 8-month-old with croup exhibits what signs and symptoms of respiratory distress? Remember, croup is that swelling in the oral pharynx. It's that barking cough. And you're going to respiratory distress. Well, retractions, right? And then restlessness because of hypoxemia, right? Good. Signs and symptoms of asthma include all except. My husband had status asthmaticus about 3 years ago for 12 days straight. It was scary, even for me. So they're going to be coughing. They're going to be short of breath. You're going to hear expiratory wheezing and a prolonged expiratory phase. They can get the air in, but it gets stuck. Remember, as it comes out, you hear that as it tries to come out, okay? In my husband's lung, I heard a little, and that's all I could hear for 2 weeks straight. He was in the ICU. Signs and symptoms of congenital heart disease include all except. What do we know about congenital heart disease and the demands on the body and possible oxygenation, right? And they're not going to eat well. They're going to be tachycardic, tachypnic. They may be in congestive failure. They're going to tire easily. They're not going to eat well, and they're not going to gain weight good. So their weight gain appropriate? Never with a congenital heart defect. No. What should you not do to children diagnosed with croup and epiglottitis? Well, remember, this is all oral pharyngeal swelling, right? You're not going to go in there and you're not going to look, because you could create more swelling in the back of their throat. So that's one thing we're not going to do. Soft tissue x-rays, you can do it. You can see swelling. If you need to, you need an IV. And always, a parent holding their child, I will always welcome it. It was part of my dissertation, that parents hold their children for injections. Epiglottis is what? What is an epiglottis? That epiglottis is that leaf-like cartilage that covers a trachea when you swallow to prevent choking. And that when it gets swollen, covers a trachea so you can't breathe. Treatment for infectious mononucleosis includes what? Excuse me. No contact sports. Infectious mononucleosis is the Epstein-Barr virus. So we don't do anything but Tylenol, Motrin, fluids, rest for mono. But the big thing is that spleen or liver can be swollen, and we don't want it to explode and die like that 9-year-old boy that I'm telling you, I'm still devastated about it. I think about him all the time. A multi-select. When doing an admission on an infant with a low-grade fever and a loose cough, what information is important? So you're admitting a kid into the hospital. Where do you place them? You know, what do you need to know to take care of them? What's most important? I mean, I know I want to know immunization status because it could be a communicable disease that if I can't put this kid in another room and I need to protect me, of course, how were the fevers? And of course, medications. I need to continue giving Tylenol and Motrin to this child. Good. What is cystic fibrosis? Now you have a case study on this. So I have a couple questions in the Kahoots that highlight on those concepts that you really need to understand. Now, cystic fibrosis is a bunch of mucus that collects in the lungs, and it's thick, and it's like a petri dish, and it just grows bacteria if we let it sit there. It also has to do with the small intestines, and it has to do with the absorption of nutrients. And this child requires pancreatase enzymes prior to eating, so they get the food they need. These children, because of all the nutrients they leave, need a higher calorie formula for the infants so that they are getting nutrition. And they also need that pancreatase before they eat. And of course, aggressive chest physical therapy. What is the greatest risk for an infant having a cardiac catheterization? You did the echo, we saw something going on. We immediately prepared this child. We know they're going to be going to a cardiac cath. They come back. What is the biggest risk here? And that's that catheter in the femoral artery and femoral vein and bleeding. So again, it's the first thing we look for. Don't get them out of bed for 24 hours and keep that leg straight, please. How is cystic fibrosis identified? I mean, sometimes we know from maybe there's a brother or sister that have it, maybe the parents. Okay. Sometimes it's they're constipated at birth. Usually you have a stool within the first day, right? Well, if you're not, this is something we'll test for. And it's one of these other things I tell you, I'm not going to tell you to do it, but if you told the parent to lick the child with cystic fibrosis, you would taste salt. Like the sweat would be full of salt. So that's what we're testing. So it tests the salt that has come out through the pores. Now, these children need salt in their diet. Don't take it out of it. They do need salt because they're losing it. A multi-select. What is included in the plan of care for a child with cystic fibrosis? Remember, it's the lungs and small intestines, and it's all about the enzymes, absorptions of food. They're losing salt. So we got to do really good with that chest physical therapy. Get it out, get them moving because it can get thick and consolidated. Pancreatic enzymes with meals, like directly before, not 2 hours before, directly with. And they need high protein. And also, if they're younger, you want more calories in their formulas that can help them. They'll need that extra. And they need regular sodium in their diet. What is the drug of choice for a pharmacological closure of a PDA? So if your PDA is open, that means prostaglandins is keeping it open. So you need the indomethacin that says prostaglandins go away, and it blocks it and it closes the duct. So prostaglandins is the hormone, that thing that's in that PDA that keeps it open, or we're going to give that in a drip. And indomethacin is the one that closes it. So is it open or do we need to close it? Those are the two medicines that go with that. What is not a feature of tetralogy of Fallot? Tetralogy of Fallot is all right-sided. It's all on the right side of the heart. So the only thing that's not on the right side is the aortic valve, which is aortic stenosis, or a narrowing of that valve. There is with it that pulmonary artery, there's something that's causing stenosis, so blood can't flow. And then when it can't flow, all that extra stuff puffs up that right ventricle, causing a hypertrophy, which is like a stretching of the muscle. And then there is a hole between the ventricles on the right and left side. There's a fourth thing that they have, that somehow the aorta gets pushed over. They call it overriding, goes over more to the right side. But remember, tetralogy, most common of all cyanotic heart diseases. This is the one you're going to see on your NCLEX, your HESI all the time. They love tetralogy to look at. And then we know aortic stenosis, left side, has nothing to do with it. What medication would you hold for an infant that is vomiting and the vital signs are 98, 88, 32? What's going on here? Digoxin. Now, infants, all you can look at is a dig level, a heart rate, or if they're vomiting. Even like nausea, they'll be retching. You'll see that. None of the other stuff you see with adults, like the halos and stuff, they can't tell you, oh yeah, I have yellow halos, nurse. It's going, no. An infant, it's vomiting, or like that nausea looking thing. The heart rate is low, and the digoxin level, we'll see the level there. And again, we check apical pulses and we check the potassium level and the dig level if there's there before we give it. Why would a child with tetralogy of Fallot not gain weight at a normal rate? Tetralogy of Fallot, they're not gaining weight normally. Why? Tetralogy is a cyanotic heart disease. They don't have oxygen, they get tired, they have no energy, they don't eat, and they're going to be below what they should be in weight. All examples of cyanotic heart murmurs except which one? Which one is not cyanotic? Aortic stenosis, there's still blood flowing there. It's not atresia. Tricuspid atresia, there's no blood going right atrium, right ventricle. That's where tricuspid valve should be. So that one definitely is. Truncus is just a wide open and it's just all this mixing and it is cyanotic. And I've told you, tetralogy is the most common of all cyanotic congenital heart defects. Here we go. What's the most common cyanotic congenital heart defect? Tetralogy of Fallot, yes. It's all right-sided, remember. Nursing care following a cardiac catheterization include what? I mean, if you think of cardiac catheterization, you think of there's these two big catheters put in the femoral artery and vein. It sort of helps you to understand what you should do post when they come back. So number one, first thing, check to see if it's bleeding. A young newborn infant can bleed out blood a lot and very, very quickly. A multi-select. Nursing education for the cardiac catheterization include all except what aren't you going to do for a cardiac cath? They're not going to ambulate and they're not going to bend their extremity, that right leg where they put those catheters. This can cause that clot to pop and bleeding to go. We're going to watch vital signs and it's going to be a pressure dressing we're going to look at. Which information is most important when rheumatic fever is suspected? What is rheumatic fever usually caused by? The other diagnosis you're going to hear about is acute glomerulonephritis, a urinary issue from strep infection. Have you had pharyngitis lately, whether you were treated or not? Did you have a sore throat? And that's going to be that, okay, we're going to treat the strep. Signs of shock in children include all of the following except shock. Does it matter? Children, adults, same thing. Same medications. You're not going to see hypertension, it's hypotension. Shock is elevated heart rate, decreased blood pressure, altered mental status, restlessness. It's going to be prolonged capillary refill, decreased urinary output. Shock, 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 shock. Hypertension, no, that's completely opposite. What is the treatment for Kawasaki disease? Remember, this is the vascularitis, systemic vascularitis. So we're going to give aspirin to stop those clots because it thins the blood and it's also anti-inflammatory, and IVIG, it's an for the immune system to boost it. Which of the following best describes pathology of Kawasaki disease? And that's that multi-system vascularitis. And we're mostly worried about those coronary arteries. A multi-select. A clinical manifestation of Kawasaki disease is So it's red-eyed, it's that strawberry tongue and cracked lips and blistered or even flaking palms and soles of the feet. And there is a rash, but erythema marginotum is mostly from fifth disease. It's a viral disease. It's more like a little macular papular rash. It's not those big blotchy ones. Which of the following is the most common cause of shock in infants and children? And that's infection. You know, they have no immune system, right? Makes sense. Especially the younger children, there's no immune system, they can't fight it. So infection can become overwhelming and it can cause shock in these children. So what are the defects associated with tetralogy of Fallot? Remember, it's right-sided. And it's the pulmonary artery is smaller, or there's a flap of tissue that goes over it. There's a hole between the ventricles, the aorta is pushed over, and that right ventricle gets a little bit stretched. It's called hypertrophy. A young child with tetralogy of Fallot may assume which position naturally when having a tet spell. You know, 2-3-year-old, they have an unrepaired tetralogy, and it happens. You know, sometimes, as I said, the symptom that you see with older children is headaches and nosebleed because of the flow going up. And that's sometimes how they diagnose these children. But they squat, they just do it. I've actually seen a kid do that in the grocery store one time. I was like, whoa. And I asked the mother, she told me, yes, it was. Transposition of the great arteries is what? What is switched? Transposition, that means those are switched. In fact, that's the name of the surgery, arterial switch operation. It's when the aorta and the pulmonary artery are switched. And you have unoxygenated and oxygenated blood, but it's not getting to the body. So we need to have that PDA open to get oxygen to the body and give cardiac output. Which of the following is not an intervention indicated for transposition of the great arteries, TGA? What is not? You know, sometimes we take and we put these children on prostaglandins and we see that, you know, it's not enough. We're going to do something called a balloon atrial septostomy. You know, there's that patent foraminal valley after birth, right? Between the right atriums and left atrium. Sometimes we have to punch a hole bigger to make the flow of blood go so more oxygen gets to the body. So that's a balloon atrial septostomy. Atrial switch is what we call it. Oral dilators do absolutely nothing. Nothing oral on this child is going to work. This child needs oxygen now, PDA. Multi-select. Why is prostaglandins given to a child with transposition of the great arteries? What does it do? If you look at that picture there, that is a temporary pacer on that child. So prostaglandins helps with oxygenation, maintains cardiac output, has nothing to do with antibiotics. Nothing. It's not an antibiotic. It is this prostaglandins is the hormone that keeps this duct open, and that duct open helps oxygen and cardiac output. What is the purpose of giving indomethacin to a neonate with a patent ductus arteriosus? Prostin opens it and indomethacin says, hey, prostaglandin, stop. You need to close now. So indomethacin closes it, prostaglandin keeps it open. Good job. Where is a patent ductus arteriosus? You've heard it at least 20 times already. It connects the aorta to the pulmonary artery, so oxygen can go to the body, okay? This heart defect allows blood to pass from the left ventricle to the right ventricle. That means there's a hole between ventricles. It could be between atrium too. And that's your ventricular septal defect, or a VSD. A multi-select. What is a sign of digitoxicity in infants? The only thing you can see in infants is either that nausea, which is like a retching, vomiting, and heart rate. That's the first thing. Of course, if you have a dig level, all right, that will help. But those are the signs, those assessments that you will see that says, I'm not going to give it a skull. Let's get a dig level. It's what it looks like. What is congestive heart failure? Does it matter? Heart failure, child, adult? No. Congestive heart failure is congestive heart failure. It's basically the heart cannot beat the way it should, and it can't pump blood. So the blood goes into the lungs and it sits there. It could be due to that coarctation, right? Which makes the heart weak. So they can't pump the blood out, so it goes to the heart. How do we treat congestive heart failure? Diuretics, digoxin. How do we monitor it? Vital signs, INO, and daily weights. Good. And of course, if you want to listen to left-sided congestive heart failure causes. And left-sided congestive heart failure usually is due to a structural issue. This is coarctation. It's kink. That hose is going backwards. What do you see? Can't go forward. That blood's going back, left ventricle, left atrium, and back up into the lungs. So you're going to see shortness of breath, coughing, fluid in the lungs. Excellent. Good job, guys. That's a really hard concept to grasp. After a heart transplant, what's the leading reason children die? Usually like within the first 6 months of life after transplant. It's rejection, nothing else. It's rejection. The heart's okay. It's just the rejection and they don't live. A multi-select. Signs and symptoms of rheumatic fever include, remember, rheumatic fever is something that's due to an under or not treated strep infection, and it attacks the body. It's usually when it gets to the point of chorea or that shuffling gait and they're not walking right and falling is when they get to the doctor. But the respiratory distress, polyarthritis, the subcutaneous nodules over the joints, and that shuffling gait, all of that will come back to the normal once it's treated. And we treat rheumatic fever by treating the strep infection. We give antibiotics that could go on for a month, maybe 2 months, but we treat the infection. Multi-select. A child's about to have a chest tube removed. What should you do? How are you going to prepare that child? I'm telling you, it burns, chest tubes coming out. Adults have taught me that. I mean, I've done adult and I've done children open heart surgeries. So number one, you're going to medicate that poor little child before you even think about doing anything. Explain that procedure on their level and be honest, it will hurt. And you don't put them in supine position. You're going to have their head of their bed elevated because once they pull, they want to expand their lungs. They want to breathe, okay? And if you have a chest incision, let's say this is cardiac surgery, laying them flat, oh, that hurts. You want them up. It helps with the pain. Take their vital signs also before and after. A child just had abdominal surgery, cannot cough well enough to expectorate secretions. What is your priority? They need to cough and deep breathe. How are you going to do that? You don't want any atelectasis right there. You don't want those lungs clogging up. You don't want them having any post-op complications. I mean, that's what we're taught, right? They're not coughing. Medicate them. Number one, medicate them. If I'm in pain, I'm not going to cough and deep breathe. So medicate them first, then move them, get them out of bed, use a set of spirometry. They'll do all of that, but first, medicate them for pain. Pain there was priority. An infant of 3 months old has a fever of 103.6. What would you medicate an infant with? Only acetaminophen, only. Tylenol is the only thing we give for the first 6 months of life for an infant. After that, we will give the ibuprofen at 6 months. There's something to do with platelet and aggregation and Motrin, so we don't give it earlier. We never give aspirin to a child unless it's Kawasaki. We just don't do it because of, Ray's disease, right? We don't want to do that. A newborn is assessed and you find very weak lower extremities. What do you think she should assess next? What do you think's going on? It's a newborn baby. It's brand new. There's I can barely feel these pulses in the feet. The dorsalis pedis, the posterior tibial. It's do I really feel this? And I'm telling you, nurses are the ones who find this stuff. And that's, you're going to look for coarctation, right? Do that 4-extremity blood pressure. See if the upper extremities are at least 20 millimeters of mercury higher than the lower ones, because there's decreased blood going down there. Good job, guys. You're one of the first classes who got that. Multi-select. A critical ill child is on complete bed rest. What a nurse can do to prevent complications. I mean, critically ill adults, critically ill children, there's certain things we need to do to help prevent, bed sores and redness and, keep their lungs moving, prevent, clots, etc. So we're going to use, instead of spirometry, we're going to keep them dry so they don't get any sort of urinary infections or breakdown. And in children, we use a lot of pillows and blankets to hold them up where they are, because when we put the right side up, that right lung is going to be really inflated. Then we turn the other side, then the left lung is really inflated. Important that we do that. And of course, you get good lung expansion on an elevated head of the bed. So all of those things above. Good job, guys. How can oxygen be delivered that is easiest tolerated and accurately monitored for infants? I mean, this week is all about, oxygen and respiratory and a lot of congenital heart defects, which means infants. And it's going to be the oxy hood for this child. I mean, many of you want to do the nasal cannula, but remember that tickles their nose, that air, and usually you tape it there to hold it. And they're like this all the time. It's not as good as the oxy hood. A multi-select. What procedure are used to keep the lungs open with a child with cystic fibrosis? Remember cystic fibrosis? It's all that mucus in the lungs and that mucus in the small intestines and poor absorption of, nutrients and giving pancreatase. I mean, how are we going to keep these lungs open? And this is like twice, 3 times a day. These parents are going to have to work with these children. Deep breathing, chest physiotherapy, exercise, ambulating, not PRN, ambulating as much as we can. I met one family that had 3 boys with cystic fibrosis, and one was a cyanotic cardiac congenital heart disease too. I don't know how they did it, because you have to give that chest physiotherapy, that vibrating thing on their chest morning and night. I mean, they had help, but wow, I having 3 kids with CF, it's hard. A multi-select. Children with cystic fibrosis require pancreatic enzyme with meals. What teaching should be done so these children are getting it right? Because remember, they need this to digest food. They're not getting proper nutrition. So you are getting a case study next week all about CF. So I hit on the really important stuff, and you'll see as you go through that case study next week. Make sure those pancreatic enzymes are right before the meals, not 2 hours before, within 30 minutes, so that it's there, it can work to digest food. Sometimes they can't swallow these capsules, so sprinkle it on the food, that's okay. But sometimes it's a powder. The only thing with that, make sure you rinse their mouth. It could, damage their teeth. And then remember, children get bigger. They're going to need a bigger dose as they get bigger. Some things that we actually forget sometimes with children. Oh, they need a bigger dose. It's been a year since last one. What is a cardiac defect when there's no valve between the right atrium and right ventricle? What is the valve in the right atrium, between the right atrium and the right ventricle? What's the name of that valve? And remember, there's 2 different words I use. I use stenosis and I use atresia, right? Without is anatresia. So it is tricuspid atresia, okay? And last question. When an infant is breathing fast, tires easily, and needs rest periods during feeding, what should you assess? What do you think is going on? Because the doctor is going to ask you things, and this is very important. This not breathing good. He's breathing fast. He's really tired. What's going on? Well, check the breath sounds. He could be in congestive heart failure. So that's what that question was about. All right, let's see how we did. Number 3, Amber. Good job, Amber. Number 2, Annie. And number 1, Mia Mary. Good job, Mia. Number 4, Shaylin. Good job, Shaylin and Angela. What I'd like you all to do is sign your attestations and get that done. Don't forget. Anybody have any questions, or anybody wants to meet me to review their exam? I don't mind, okay? Just let me know. If it takes 5 minutes, it's 5 minutes. But let me know it's a good time for you, and I can see if within my schedule I can fit you in. But I will make every attempt to. Did you
Is the
learn?
quiz that's on there right now
You can go for it. It is right to go with that. I have talked about everything.
Okay, thank you.
Okay? That's the one thing I've always told you. My lecture, my cahoots, well, everything is covered on the quiz. Good luck, guys. Thank you for everything. Good night.
Thank you.